I'm here with Dr. Liu in Northern Colorado Medical Center, and just had a few quick questions. If you want to introduce yourself first, you can go right ahead.
My pleasure, yeah. Dr. Scott Louie, an interventional or advanced endoscopist, currently working at Northern Colorado Medical Center in Greeley, Colorado.
Great. So we just had a few questions around choledocholithiasis. For starters, what is the current algorithm for a patient that comes into the ED or ER department with choledocholithiasis or suspected of?
Right, so typically these patients are going to present with right upper quadrant abdominal pain, and for those who are suspected to have choledocholithiasis or common bile duct stones, typically going to see dilated bile duct on imaging. The most common initial imaging for evaluation patient with right upper quadrant abdominal pain and suspected gallbladder or bile duct issues and abdominal ultrasound. Least expensive, least invasive, and readily available. So that you can determine if the patient has or doesn't have gallstones and whether or not there's bile duct dilation. Along with that, you're going to get liver enzymes, and if they have a patient has hyperbilirubinemia, you can define somewhere in the greater than 2 or 3 on the bilirubin, and they have a dilated bile duct, then that pre-test probability of having a common bile duct stone is high, particularly if they have also gallstones. And in that particular patient, then an argument could be made to consult GI, proceed with an ERCP. The patient's bile duct is either not dilated or minimally dilated, and the bilirubin is not elevated, but they have gallstones. Those patients commonly just sent for referral to surgery to have a cholecystectomy, presuming they're symptomatic of choledocholithiasis or cholecystitis. It's the challenges when the patient has borderline bile duct dilation or no bile duct dilation or minimally elevated bilirubin, which can happen with just gallstones. And in those patients, traditionally, it depends on the access of endoscopic ultrasound versus lack of access of endoscopic ultrasound and MRCP. Historically, commonly those patients are going to get an MRCP or MRI with contrast, so a MRI cholangiogram, and that has a very high sensitivity for bile duct stone, but it's not 100%. There's small stones, particularly 5 millimeters or less, that can be missed. So in that situation, endoscopic ultrasound has much higher sensitivity. So if there's any question in that setting, we would proceed with endoscopic ultrasound and consent the patient for ERCP. If the EUS shows a bile duct stone, then they get an ERCP in the same setting. If the EUS is negative, then they would not get an ERCP and proceed with cholecystectomy. If for some reason EUS is not available, for example, on that day, one of the advanced endoscopists is not available, or the surgeon gets called first, they may get an MRCP. And if that's negative for bile duct stone, then the patient could go on cholecystectomy with or without an intraoperative cholangiogram. Now, some of these algorithms are affected by whether or not you have surgeons that are capable or willing and routinely do intraoperative cholangiograms. In CMC, we have surgeons covering that are both capable and routinely get IOCs, and so they could go with a cholecystectomy, shoot an IOC, and then consult surgery or consult gastroenterology for an ERCP after the fact. Now, there are those patients that say get an MRCP and no bile duct stone is seen, and then the surgeon may then shoot a cholangiogram intraoperatively and find a delayed or lack of contrast passage into the duodenum, or actually see a filling defect consistent with stone, and then they would consult us for ERCP to follow the cholecystectomy. So in general, it's what's the pretest probability or likelihood of a common bile duct stone in the patient that's presenting, and that's largely driven by bilirubin and or liver enzyme elevations in the presence or absence of dilated bile duct on imaging.
Great, excellent. And then my final question would be, based on the criteria, is there a setting where it would be beneficial for a patient if the surgeons have the capabilities and tools to perform common bile duct exploration? What criteria would that patient, meet for them to be more susceptible for a surgical first approach? And then which ones would be better for ERCP? Is there a distinct between those two patients?
Yeah, it depends on the local surgical expertise. So historically, most common bile duct explorations were done open. So in the era of pre-laparoscopic cholecystectomy, patients would have open cholecystectomy and they could shoot a cholangiogram intraoperatively. And if there was a stone, they'd do an open bile duct exploration, but that involved incision of the bile duct and typically the placement of a T-tube drain in the bile duct that would be left and then removed at a later date. In the modern era of laparoscopic cholecystectomy, surgeons are able to routinely get the gallbladder out as long as there's no marked inflammation with adhesions that causes them to have to either convert to open or abort and do a subtotal cholecystectomy. They will concentrate on getting the gallbladder out and not and shoot an intraoperative cholangiogram by shooting dye through the cystic duct. And then if they see a stone or lack of contrast emptying into duodenum, then they would refer for ERCP. Now, what's happened more recently, particularly with the availability of and experience with laparoscopic surgeons that are adept at and willing to do intraoperative cholangioscopy through the cystic duct and even do interventions such as stone lithotripsy, or stone extraction, or even flushing stones through the papilla. Surgeons can do laparoscopic bile duct exploration. And what many people don't understand, even some gastroenterologists, that doesn't involve incising the common bile duct, which is deep, sort of going retroperitoneally and difficult to access laparoscopically, but it involves transcystic. So the surgeon is accessing the cystic duct as they would for a intraoperative cholangiogram, but they can then, with the Boston Scientific cholangioscope that's designed for surgical intraoperative cholangioscopy, they can enter the bile duct and do what historically, in the more recent past, we as gastroenterologists have done is the SPY glass or single operator direct cholangioscopy transpapillary. Now surgeons, if they're interested, skilled, adept, experienced, can actually do what we do, but do a transcystic. And so as long as the cystic duct is not too tortuous and occluded, they can go in through the cystic duct into the bile duct and do direct visualization of the bile duct, see stones and or strictures, even perform EHL or mechanical lithotripsy and deal with the stones, use a trap, extract it either through the cystic duct. Some surgeons will push it through, flush it through the papilla. There's some concern about that, whether that will increase the risk of pancreatitis. That's been reported, but in general, this has created a new twist in the algorithm because the mandatory GI consultation for ERCP to deal with common bile duct stone doesn't necessarily apply any longer. It becomes more, as you asked, a collaborative effort and multidisciplinary approach. What is the local expertise both and availability for both surgeon and or gastroenterologists to either do ERCP, cholangioscopy, lithotripsy, mechanical or EHL, or the surgeon to do that. So that opens up the options. And certainly ERCP carries its own risk of pancreatitis, bleeding, operation, but this, saving, coordinating the time for both cholecystectomy and ERCP sometimes can be difficult when the gastroenterologist is available. It may not be work with the surgeon. So if the patient's already under general anesthesia getting cholecystectomy, and the surgeon has the capability to do intraoperative bile duct exploration transcystic, then and can do lithotripsy, then that may save the patient a second anesthesia and procedure the next day for ERCP.
Great. Excellent. Thank you so much for your time. I
You're
appreciate
welcome.
everything.
Thank you.